Good evening from Goa, India, where I join you today for this very exciting event. I'd like to start by wishing each and every one of you a peaceful and a healthy new year, one that I hope brings us a lot more positive spirit about what lies ahead for a better world, a world in which we can rally around each other and in solidarity transform the communities that we live in. With that theme in mind, I would like to speak to you today about the historic opportunity that we all have, those of us who are so passionate about mental health, to transform the way we think about mental health and we address mental health in our societies, in our communities, in our countries, and indeed in our world. Let me start by thinking back about the time when I started working in mental health issues in the community in the early 1990s. I had finished training in Britain in one of the world's best psychiatric residency programs at the Maudsley Hospital in London, and found myself working in primary healthcare in a very different context, that of Zimbabwe, where I was one of 10 psychiatrists in a country with about 9 million people. I remember that I had to relearn almost everything about mental health care in my 2 years there. And in particular, I also remember having to face a number of different myths and ideas about mental health problems that I had never encountered before. These were myths that also persisted when I then returned to India in 1995. The myths included the fact that people thought that mental health problems were a Western problem, a problem of European people and European countries. We didn't see that in Black people, in brown people, in developing countries. Mental health problems were seen as a product of Western culture, and somehow cultures that were not European had protective mechanisms that protected its people from developing mental health problems. Another myth was that mental health problems were a luxury item for poor people and for poor countries. There were far more important things for poor people to think about, such as, for example, food security, housing, and physical health problems. Yet other critiques, particularly from anthropologists, suggested that most mental ill health was simply an extension of social suffering. That is to say, when people had difficult lives, lived in disadvantaged communities, lived in oppressive regimes, there was going to be misery. And what psychiatrists and medical practitioners call mental illness was actually simply the human experience of living in very difficult political and social circumstances. The implication, of course, was that the solutions lay not in health interventions, but in political and social interventions. There was yet another critique that particularly came from health economists who were considering how best to allocate resources for health conditions in parts of the world where there were limited resources for health. From their perspective, because you couldn't really diagnose a mental health condition in the way that you could, for example, diagnose tuberculosis or diabetes, that these were not really serious health conditions. What people told you about what they experienced was never considered as serious as a biological test, such as a blood test or as an x ray. And finally, these very health economists would also tell us that it was too far expensive to treat mental health problems. And poor countries with limited resources simply couldn't afford mental health care. Of course, the assumption was that mental health care involved expensive providers and expensive treatments given in expensive hospital settings. Over the next 25 years, I have worked through research in partnership with community-based organizations, government providers, and universities to address through science each and every one of these myths. And today, if I had to summarize the lessons that I have learned primarily from my work in Zimbabwe and India, but also in many other countries in sub-Saharan Africa and in South Asia, I could summarize it as this. First, mental health problems are universal health experiences, just like physical health problems. In fact, they have very similar core features across cultures and contexts, and people in different parts of the world respond similarly to mental health interventions. This is not to say that culture is not important. It's profoundly important. But culture doesn't mean that mental health problems only occur in one cultural group and not in another. Second, mental health is inseparable from one's personal life story, in particularly one's early life experiences, one's physical health, and one's socioeconomic conditions. And because these different aspects are unique to every person's mental health is a unique story in and of itself. And any attempt to categorize and group people in a diagnostic way, as we could do, for example, for COVID 19, will always be inadequate to understand mental health from a person centered approach. Third, that mental health care cannot be viewed purely as a biomedical professional entity. It must embrace a diversity of perspectives, experiences, and providers. And I'll speak a little bit more about this in my talk as we move along. And fourth, people with a lived experience of mental health problems must be central to all aspects of mental health care, defining, for example, what the goals of mental health care are, how mental health care should be delivered, their own role in mental health care, and holding mental health care accountable. And in many respects, this last slogan or this last message is one I have embraced from my observations of the HIV/AIDS movement, where people living with HIV/AIDS have placed their own life stories, their own health, and issues of justice and human rights bang in the center of HIV/AIDS health programs. It is this body of evidence, and of course, here I must acknowledge the hundreds, if not thousands, of mental health practitioners, advocates, and activists from around the world, particularly in the global south, that has led to a transformation of our understanding of what mental health looks like globally and how we should address it. It is this science and experience that has led to the emergence of global mental health, which is a discipline of global health. And here you can see the definition of global health. And I've inserted the specific words mental to indicate the specificities of global mental health within the broader definition. But I've also highlighted something here which I think is extremely important about global health, and that is the idea of justice and equity. And this recognizes the fact that mental health is disproportionately distributed in the population, and people who have been historically or socially disadvantaged have much poorer chances of achieving good mental health than those who are better off. And this is true for all countries around the world. And in that respect, mental health is truly a global health subject because every country is failing when it comes to mental health. Every country, in some respects, is developing when it comes to mental health. I want to turn to the opportunity that science has presented us to reimagine mental health care. And I want to start with the very important initiative that the National Institutes of Mental Health of the US launched about 15 years ago now. I co-chaired this initiative with Pamela Collins, and it was called the Grand Challenges in Global Mental Health. The aim of this initiative was literally to identify the big questions, the grand challenges, which, if addressed through science, through research, could make a significant impact on reducing the burden of suffering due to mental health problems around the world. And this Grand Challenges exercise was the third in the health area, the first one being the Grand Challenges in Global Health, launched by the Gates Foundation, that focused on infectious diseases and maternal and newborn health. The second Grand Challenges was on non-communicable diseases, and this third one focused on mental health. This was, in essence, a research priority setting exercise in which we assembled a group of nearly 400 global mental health practitioners across disciplines, across countries, across perspectives, and asked them, what do you think are the most important challenges in global mental health? And then, using a systematic approach, we boiled these down to 40 challenges. What was very important in the results of this exercise was the leading challenges, the top 5 or 10, were not about discovering new aspects of mental health problems, for example, a new gene or a new molecule or a new biomarker, but they were all about doing better with the knowledge we already had, in some cases, for 30 or 40 years. They were all essentially around implementation questions, delivery questions. Following the publication of the Grand Challenges in Global Mental Health, a variety of research funders joined hands and have since then committed more than $500 million of research money to back science that seeks to address the grand challenges. Today, I'm glad to tell you that we have some definitive answers from this body of science that tell us that we know how to deliver clinical and preventive interventions in an affordable and acceptable way in any resource setting, regardless of the strength of their mental health care system, regardless of how many mental health specialists or resources they have. Every community, in every context, provided they are given adequate support and empowerment with knowledge, with science, and a variety of other tools, can be engaged with mental health care. There's a range of different systematic reviews, and I've just listed a few at the bottom of the slide that have brought together evidence that has emerged from more than 100 randomized controlled trials across the full range of mental health conditions from more than 60 countries around the world. One of the pioneer organizations in this area has been the NGO Sangat that I worked with for 25 years in India. Sangat is a community-based mental health implementation science organization located in the state of Goa, where I'm speaking to you from today in my home, but which also works across the country. And on this slide, you can see a variety of different randomized control trial publications that depict the range of work that Sangat has been doing in the area of improving access to care in the community for people with a range of mental health problems, from schizophrenia and autism through to mood and anxiety and alcohol abuse conditions. But beyond treatment and care, Sangat has also been working in prevention and promotion, and you can see examples, for example, of a school health promotion intervention in the top left-hand side. Sangat has also been one of the pioneers in exploring the way digital innovations can be used to transform mental health care. I'll talk a little bit more about the first innovation, about building a workforce by using digital platforms. I also wanted to refer to delivering interventions, not just through games that Sangat has developed to help teach young adolescents in schools problem-solving skills, but also more cutting-edge work, such as the use of digital games to assess early life child cognitive development and assessing behavioral biomarkers for people with chronic schizophrenia. Mind you, all of this is being done in rural settings in India. So they may sound incredibly sophisticated. And for some of you may say, well, this is not really relevant to poor people in poor countries, but actually, these sorts of digital tools are transforming our understanding of how we can bring the most sophisticated mental health assessment and interventions to the poorest communities with the least resources. And the final example is the use of social media and the internet more generally to engage the public in conversations about mental health. And of course, which demographic engages with social media more than young people, who are also, of course, the demographic who are most vulnerable to develop mental health problems. I just want to show you a very exciting program that I'm particularly very excited about because it's led by young people in Sangat that shows how storytelling around mental health is being used as a way to engage young people and to combat stigma around mental health. This program is called Man Mela, literally Museum of the Mind. And here goes.
It's not always easy to talk openly about our mental health, both our struggles and our victories. But when we do, we let others know that they are not alone. Sharing our stories with others can inspire them, offer hope, and help them. Man Mela is a museum about young people's mental health stories from India. We feature stories from different parts of the country that tackle common misconceptions about mental health, highlight common problems, and share information on how to seek help and build resilience. Our storytellers work with a team of researchers, writers, and designers who help bring their stories to life using art and technology, enabling viewers to interact with their worlds as they travel through journeys of finding hope, identity, meaning, and empowerment. Our stories matter, and telling them can make a big difference.
It is this kind of evidence that is, by the way, this is not the only organization, of course, working in this area. There are hundreds around the world, and they all are working in very innovative ways. But if I had to synthesize all of this body of evidence, I can tell you that we can redefine mental health care today. For example, redefine what comprises mental health care as one example, recognizing that the social determinants of mental health are inseparable from the clinical experience of mental ill health, and that any intervention which is likely to have a long-term benefit must simultaneously address both the symptoms as well as the social determinants. The where mental health care can be delivered anywhere where people are. We need to go where people are rather than to expect people to come to us. This means working in schools, in community centers, in primary healthcare, and people's homes. Who, anyone with appropriate training, appropriate supervision, can become a mental health care provider. Community health workers, nurses, midwives, teachers, lay people, peer support workers. And how? Through a coordinated approach which ensures that these frontline workers are supported and work within a collaborative care framework so that those individuals who they are helping, who need more specialized care, can be rapidly seen by more specialized mental health providers. But also equally, those who have seen a mental health provider can be referred back to frontline providers to support them in continuing care. This evidence is already transforming mental health globally. On this slide, you can see two documents at the extreme ends of the slide that reflect global policies. On the left-hand side, the World Health Organization's Mental Health Action Plan, and on the right-hand side, the World Bank's Mental Substance Use Disorder Neurological Disease Control Priorities volume. And in the middle, you can see a country policy. The country policy here is India. I was involved with drafting the India's national mental health policy, and I can tell you, when we presented the evidence that came from Sangat and a number of other agencies in the country, there was no question that the policy chose community-based mental health care through frontline providers as the foundation of its mental health care system. 10 years ago, none of these bodies, either nationally or globally, would have said that this was a reasonable approach to actually recommend. Today, it is the first thing that people recommend, and this is a testimony to the power of science to change the ways we think about health more broadly and mental health more specifically. So there's the opportunity, but what's the threat? Let's just first of all look at the threat in terms of access to quality care for mental health problems. This slide comes from a very recent paper led by Daniel Vigo that looks at the effective coverage for depression in low and middle income countries reported by participants in the World Mental Health Surveys. I've highlighted two different bars at either end of this chart. What the left-hand bar tells you is that about a quarter of all the people with depression in these surveys had sought care for their depression, which means that 3/4 had not. But only about 5% of all people with depression received care that the researchers considered to be sufficient quality. That is to say, that met the criteria of what we would consider evidence-based interventions. What's the picture like in high-income countries? Well, you see a much larger proportion of people who have sought care, about half. But you can also say, therefore, that half of everyone with depression in wealthy countries hasn't sought care for their depression. And look at the figure of a proportion of people who receive adequate quality of care, just about 10%. The important point from this particular slide is that even though wealthy countries spend so much more on mental health care, the results are not really proportionate to how much they spend. We should have seen far better metrics of contact as well as effective coverage. And this tells us that simply spending more money on very biomedical models of care, which is typically led by specialists from hospital settings and focuses on narrowly defined clinical interventions, will never be sufficient to achieve reasonable levels of coverage for depression care in the global context. What about more serious mental illnesses? For more serious mental illnesses like the psychotic disorders and psychosocial disabilities, this is the appalling state of care that you see in many developing countries. These are all images of mental hospitals from low and middle income countries. These are horrifying images that my mentor, Arthur Kleinman at Harvard Medical School, has described as a failure of humanity. People often talk about stigma attached to mental health problems, like as if these are ideas that people have in their minds that require correction by teaching them about mental health. There's a sense that these are primitive ideas. I believe that actually these are not primitive ideas at all. They actually reflect people's experiences of mental health care in many countries. Which other health condition is associated with being taken away by the police in handcuffs, being locked up in a room, having people jab an injection into your backside, all without your permission? If this is what happens to you when you suffer from a mental health problem, wouldn't there be stigma attached to it? Indeed, I believe that these sorts of horrible kinds of care experiences for people with mental health problems are one of the principal reasons why stigma exists for mental health problems. And if we have to address stigma, we have to start by changing the face of mental health care, particularly for people with serious mental illnesses. Now, it has to be said that in rich countries like the US, where I spent part of my life, we don't see such horrifying mental hospital images anymore. But what we've done in the US is simply replace the mental hospital with a different kind of locked room, the prison. Look at this shocking statistic on this slide. Either you're in prison or you're living on the streets, and every now and again, you're likely to be shot by the police because somebody complained that you were behaving oddly or disturbing the peace. What's even more worrying is that, at least in some countries, mental health indicators have shown a worsening in recent years. These are from the CDC data on suicide rates by age in the US for the last decade. And you can see a rise across all age groups, but look at the shocking increase in young Americans, adolescents, and young adults, a 50% increase in the last decade. This is not only true, actually, in the US, but also in some other wealthy countries like England and Australia, where again you see here for young men and young women, dramatic increases in suicide mortality in the last decade. Of course, COVID-19 has transformed all conversations about mental health. The enormous uncertainties that populations around the world have experienced and the disproportionate impact of the epidemic on certain groups in the population, particularly poor people, women, and adolescents, has meant a dramatically increased burden of mental health related suffering. Here I present data again from the CDC from June of last year. Here you can see the prevalence of anxiety and depression in all Americans, and then for young Americans in terms of anxiety and depression on the left-hand side and seriously considering suicide in the past 30 days on the right-hand side. It's astonishing. 2/3 of young Americans in this survey in the middle of the pandemic reported having clinically significant symptoms of depression or anxiety, and about a quarter had reported seriously considering suicide in the past 30 days. If you break down these data by different subgroups in the population, you also see a similar pattern of inequity with people. If you look at the extreme bar on the right-hand side on both sides of the chart, those are the least educated groups in the population, and you will see the highest rates of both anxiety and depression and suicidal thinking. And of course, this replicates a well-described finding of the increased burden of mental ill health in socially disadvantaged groups. The future, sadly, could be quite bleak unless we act now. Already, several hundred million people have been pushed into poverty and more than 100 million into extreme poverty. That is a level of poverty that can lead to acute impoverishment, hunger, and death. Let us not forget that the financial recession in 2008 was largely a US phenomenon. But even that single country recession led to a surge of mortality and a fall in life expectancy in working class Americans driven by suicide and substance use. This constellation of mortality has been described as the deaths of despair, not the deaths of hunger, not the deaths of homelessness, not the deaths of poverty, the deaths that occurred because people lost hope, lost meaning, lost purpose in their lives. And of course, the Nobel Prize winning economists Angus Deaton and Anne Case have written about this kind of mortality pattern. And I think we should all be worried about the global impact of COVID-19 that has affected economies everywhere and affected poor people disproportionately everywhere, on what the impact will be on rising mental health related mortality in the years to come, unless we reimagine mental health care and do it now. A few years ago, the Lancet Journal invited me to co-chair a special group that we put together called the Lancet Commission on Global Mental Health and Sustainable Development. We published our results in 2018. We could never have imagined back then that there would be a pandemic in a year's time, which would make the findings of our synthesis of evidence so very relevant and timely. This particular this particular commission synthesized all the evidence I presented to you earlier about the dramatic new ways about thinking about how mental health care can be delivered in any resource context, and issued a series of recommendations on how this science could be translated into practice. Today, I want to leave you with some key messages that I think are very relevant when we think about reimagining mental health care. First, we must look beyond narrowly defined diagnosed mental illness as the only way of thinking about mental health. We must move away from binary models that classify people into people with a disorder and without, and recognize that mental health problems exist on a dimension, and that we can act and support people who have distress even without the necessity of establishing a clinical diagnosis. This allows us to also begin to target preventative interventions, particularly by addressing structural and social determinants across the life course, but especially in the first 2 decades of life, when we know environmental factors have the greatest impact on the developing brain. We need to adopt a rights-based approach so that the horrifying reality of coercion and institutionalization is eradicated altogether from mental health care. That ultimately we can live in a world where all people with mental health problems enjoy the same rights as people without mental health problems in terms of access to quality care, which they wish, which they desire, and which they consent to. And that we need to look for a future where we can assure the quality of care, not just by ensuring that they get access to medication, but also get access to the incredibly effective range of psychosocial interventions that can be delivered through frontline providers. I want to end by telling you about one program that I'm involved with, which is specifically seeking to implement the last of these key recommendations. I'm also involved with the others, but time doesn't permit me to talk about all of these different actions that I'm involved with. And so I'm going to only focus on the last one, which I think hopefully will also be something that resonates with many of you who are working in this sector. And this is a program that is using a digital solution to enable frontline workers to learn, master, and deliver quality assured psychological treatments. Empower isn't a single app. It isn't about directly giving people with mental health problems tools to figure out how to deal with their own mental health problems using some kind of CBT app, but instead it's a suite of digital tools, many of which already exist, that can be used in a coordinated way to build the workforce, the frontline workforce, to deliver mental health interventions. Now, one of the main reasons why psychological treatments delivered by frontline workers hasn't gone to scale, even though hundreds of trials show it's effective, is because in order for it to go to scale, we have to train and supervise these frontline workers. And currently, we're still using an 18th century model of training and supervision, which is bring workers into a workshop, make them spend 7 to 10 days in that workshop, get an expert, sometimes from another country, to train these workers, and then to have supervision by experts. You can quickly see why this will never scale up. It's impossible to imagine doing this for the millions of providers we need to train globally over the next year or two. What Empower is doing is using the well-established methodology of using digital platforms for learning, and then a novel way that we have developed with NIMH support to convert evidence-based manuals of psychological treatments in a systematic way into online curricula that people can learn on their own and occasionally with coaching, all done remotely, to learn how to deliver an evidence-based treatment. And then they can master the treatment through online delivered supervision, particularly peer supervision. And then once they've done that and they're credentialed, they can now start delivering the treatment using online tools to help deliver treatment with quality and to continue supervision with peer supervision as the primary modality of supervision, which also will help generate quality metrics of the therapy they're delivering. And as we train a sufficient number of frontline providers, the data that we can collect from this large number of providers can then allow systems to evaluate the impact of the scale up on population level mental health and a number of other very interesting science-based analyses, such as looking at which aspects of quality and competency help predict patient outcomes, and therefore, in some ways, unpacking the black box of psychosocial interventions. We are now adapting and digitizing this curriculum for frontline providers in the US. And I want you to pause for a moment and think about how provocative this is, how audacious this is. We're taking a treatment that was developed, designed, and delivered by frontline workers in India. And therefore, all of it was in Indian languages. And now we have a team of psychologists and mental health professionals in the US taking this Indian script, blueprint, and treatment and adapting it for the US. This is exactly the opposite of what usually happens, isn't it? Where treatments are developed in the US and then adapted in Spanish or adapted in another language. Here, you're seeing the opposite. And what Empower is enabling us to do, therefore, is to really embrace the idea of global and global mental health, where lessons, where innovations, where ideas can flow in both directions, from wealthy countries to less resourced countries and vice versa. I'm thrilled that we have tied up with a number of different partners in the US, the Wellbeing Trust, the Meadows Mental Health Policy Institute, and we are also now building new curricula over the next year for trauma, as well as for mental health promotion and wellness promotion that will hopefully be scaled up throughout the US in the years ahead. And of course, we're doing similar work in India as well. Ultimately, what Empower seeks to do is to help naive learners like community health workers complete online training so they become competent learners. They can then, through case-based supervision, using the supervision platform, become competent providers. And then as they deliver this treatment at scale after being credentialed, they'll gradually become experts. So that, as you can see over time, we do away completely with the need for external experts because the program itself is generating experts through its own providers. This is the only way that we're going to deal with the rising demand for mental health care. If we stick with the current system with a limited number of providers, and most of whom are mental health professionals, the number of people we help is going to remain the same as it was before. On the other hand, with the empowered model, we can dramatically increase the supply in a very short time. Imagine, for example, when we have the US script for Empower for depression ready, which will be around June or July this year, theoretically, we could train every community provider in the US by December. As long as there were implementers who were interested, the learning material, the validated learning material, is available for anyone to learn. And that is the incredible thing about digital platforms in terms of rapidly scaling up these sorts of interventions. And therefore, the number of people you can help is, of course, exponentially greater. In closing, I believe that the evidence that global mental health practitioners around the world have been generating is transforming and reframing mental health, not just as a biomedical condition that is important to mental health professionals, but as a global public good, as something that is universal and that is an indivisible part of who we are as human beings, that is important to all of us at every point in our lives, and especially important to young people. And of course, COVID-19 means that it's never been more important. Of course, we need to invest more in mental health. This is truly a historic opportunity to do so. But why we ask for more money? We must spend it wisely. We shouldn't just pour all this money into the old-fashioned ways of doing mental health care, but instead, we need to reframe mental health guided by the best science and a strong human rights foundation. And to do that, mental health care must embrace the diversity of experiences and strategies that global mental has shown work. Thank you very much for your patience.
Thank you so much, Dr. Patel. That was really, really exciting, actually, to hear about these incredible opportunities, especially considering, we're here in Latin America in contexts where we face so many mental health challenges, such high rates of violence and trauma, and where culturally we're used to, a very traditional clinical approaches. So this is really exciting to hear about these models, these proven models that can be replicated and scaled in other contexts. So thank you so much. I think just that provides a lot of hope for all of us as a broader community of practice. And I think along those lines, I wanted to ask you something, following up on what you just spoke to us about. How do we change the paradigms? How do we change the paradigms that are so deep rooted that really prevent us from moving towards a system, or at least have prevented us thus far from moving towards a system that really leverages the strength of not only people with lived experiences, but also, when you call them lay counselors or frontline workers. How did that happen in India, where you were able to really generate that change? And how can we do that in Latin America, in a region where we're still kind of focused on psychologists, psychiatrists, and social workers as being the only people capable of addressing mental health challenges?
So I think that's a really important question, and I can't emphasize how important it is to have firstly a scientific foundation for this. We can all have ideological positions. I could have said what I've said 20 years ago, and I would have been pilloried because I had no science to back what I was saying. People would have said, this is unsafe. You're creating dumbed down solutions for poor people. Instead of getting their countries to invest in more psychiatrists and psychologists, you're selling a cheap model of care. You've heard these arguments before, surely. And I think, therefore, science is terribly important. And this science tells us many things, not just that you can deliver mental health care with appropriately trained frontline providers, but also that you don't need such complex interventions, that actually very parsimonious interventions. Just behavioral activation can actually help 2/3 of people with severe depression recover within 3 to 12 weeks. I mean, this is not just the provider that we're changing. We're also changing actually the nature of the intervention itself. And this is therefore cutting edge science in many ways. So science is very important. Without science, I believe that you can't really change anyone's hearts and minds on this issue. Once you have the science, the other thing we've done is we work very closely with two very important stakeholder groups. The first is the policymaker. Because policymakers are also very frustrated. They do recognize in many parts of the world that mental health is a very big challenge. But when the only solution that they're being told can be used to address that, which is more psychiatrists, more psychologists, more hospitals, and more medicines, when they know that this is not actually what communities necessarily want, but they also know they don't have the money for that kind of investment, they just simply phase out and say, well, we're not going to do anything. So you've got to get policymakers on board. And when you present them this science, actually it excites them, because for them, this is what they were already doing for TB care. They're doing this for HIV/AIDS care. They're doing this for diabetes care. So this is completely aligned with existing programs for NCDs and infectious diseases. And the other important stakeholder are communities themselves. To get communities to demand mental health care, to demand that the frontline workers who are otherwise coming to their houses and providing maternal care and childcare are also equipped to deal with psychosocial problems. And so when they demand it, actually there's also an incentive for health systems to respond to that demand. More recently, I have to tell you, the greatest success I feel now has been professional bodies joining hands. Today, the World Psychiatric Association openly embraces the ideas that I've spoken about today. The American Psychological Association, which is the largest body of psychologists in the world, has partnered with Empower. We are working as partners to actually bring Empower to the US. So, I think science is the biggest driver, and then you create a coalition that actually seeks to make mental health important rather than mental health professionals as the central goal of a mental health policy.
Thank you. That makes a lot of sense. Thank you so much.
If I may jump in, thanks so much, Dr. Patel. That was super interesting and very how can I say, from a very conceptual framework and then down to the interventions that can highlight and can lead us to some of the uh, of the things that we have to do in this region, as Selena pointed out. I wanted to ask you something about, you mentioned this the quest, I would say, this quest of reimagining mental health, and we are in this quest reimagining educational sector. We are reimagining our economic paradigm in the globally, but also in the Latin America and the Central America and in El Salvador, Honduras, and like these small countries. Um, what what is for you, like what can you tell us about, let's say, the groundings or the foundational grounds for this reimagining process? And I wanted to ask you also more about the foundational grounds, but also if you would say that there are some universal interventions vis-a-vis targeted interventions. I mean, is there something that we need to see in this reimagining process, that there's some preventive interventions as universals for everyone, and some targets or for some very specific situations?
Yeah, absolutely. So let me tell you the one foundation that I think unites all the reimagining, and that foundation is that of justice and equity, of fairness. And by that I mean two things. First of all, I mean justice and equity across nations, that we all have to share this planet together. This pandemic has taught us that a disease outbreak in one part of the world that involved very much issues to do with climate change, planetary health. This infection is a zoonotic infection in many ways. It came out of the forests. But look how it spread and crippled the whole world within the space of a few months. And so it tells us, first of all, that we're all interconnected. And there are even more important issues that affect all of us. Actions in one country will affect people in another country. Climate change is another really, really germane example of that. So that's the first thing, that we have to think as a global community and act locally. Whatever we do locally has to be thought through in the global sense, in global context. The other kind of equity is that locally we have recognized that people have very different life chances from birth. And those life chances are built and structured around history, as well as the socioeconomic conditions of their families. And of course, these are often kind of interface with each other. And as long as we do not acknowledge that, we will have only worsening inequalities between countries and within countries. And inequality, in my mind, is the single biggest threat, not only to our planet, but to human health as well. So I think all of these, whether it's education or work or health, I think that there's one unifying feature. It's about creating a fairer, just world across the countries and within countries as well. In terms of prevention, I'm very passionate about that. As I mentioned earlier, didn't get much chance to speak about that because of time. But actually, the most exciting prevention work is universal. It applies in all populations. It has been shown to apply in all populations, and that's early life promotion of child development. Now, we've often seen child development as a kind of a separate silo, and this is another big problem in the field of mental health. We've broken it up into so many different silos. You've got a separate silo called early child development, which talks nothing about mental health. You've got those people working with children with disabilities who don't talk about mental health either. Then you've got people who talk about mental health problems. You've got another group talking of substance use, another group, so much fragmentation. But if you really look at the science of mental health, you will see that the single most important predictor of poor mental health is adverse childhood experiences. And what is the mechanism? The mechanism is between poverty-related adversities, violence, trauma, etc., in childhood, creating cognitive impairment. And it is that cognitive impairment that then has impacts on the experiences of mental health, initially through affecting your learning abilities, your economic opportunities, and so on. So there is a continuum here. And so the most powerful interventions that I invest in are interventions in the first 2 decades of life with very young children. Those are the scaling up of parenting interventions, which are universal. And in fact, of course, there are cultural factors, by the way. Let me not, of course, there are cultural nuances, and that goes without saying. But the core elements, responsive parenting and reducing toxic stressors, I think that applies across all contexts. Empower is actually got a separate group. I didn't show it on my slide, that is specifically working on a curriculum for parenting in partnership with UNICEF as well. And then the other area is adolescence in schools, where the focus is on school environments around, for example, promoting school climate, which is really around trust, a sense of agency that young people have when they come to school, both between students, addressing things like, for example, gender, as well as between students and teachers. To me, this is really exciting, because if there's something that is going to reduce the burden of mental health suffering, it isn't going to be better treatment alone. In fact, better treatment will only play a very small role. The only way we can genuinely reduce the incidence of mental health problems is through prevention. That is the only way we've been successful in reducing the incidence of any other human health condition. It's not through treatment, it's through prevention. And that is what I think we should be investing in.
Thank you so much. That's, it's music to our ears, I think, in the region. Jimmy's smiling because we've been looking at all these spaces. And like you said, it's been fragmented. Where else can we think about working on this outside of school systems that you've seen effective, particularly working with lay counselors? Like community spaces,
So, I already mentioned in my early remarks that, if you look at the life course perspective, you have to ask yourself the question, what are the environmental influences that are most relevant at different stages of the life course to the developing brain? So we know that before you go to school, the most important environments are at home. In early childhood, after you started going to school, there's a mixture of home and school. And when you reach adolescence, peer environments become the most important. So the way to think about interventions is really according to the life course stage you're at. And that's important. It's also important to keep in mind that the timing of your interventions will be greater the earlier in life that you actually put them. So these are two broad principles, that the environments change as you grow from 0 to 18, but also the closer to 0 that you intervene, the more impact you'll have. It's a far more efficient time. So therefore, I would say the most important policy imperative is early child development. Reducing the experience of adverse child experiences, both in terms of structural interventions, but also targeted interventions for those families or children growing up in families where there are adversities, either social adversities like poverty, but also adversities that you discover, for example, due to the death of a parent, etc. So that's one big chunk, which is not in schools. Obviously, schools have different needs in primary and secondary and preschools, of course, which are also increasingly important. The other environment is the neighborhood. And the neighborhood is something that we haven't got a very good sense of yet. I mean, there's some terrific work happening in many parts of the world on neighborhood interventions, but neighborhoods tend to be a lot more varied. And so it's very hard to distill what might be the effective strategies. It's going to have to be grassroots based. It has to be participatory. And those principles are pretty generic. But there isn't a single kind of intervention that would be classified as a classic neighborhood intervention, apart from neighborhood violence. I mean, I think that clearly is something that affects everyone's mental health a neighborhood where there's security, where you can trust the police, where you can walk at night without the fear of being attacked, etc. So neighborhood safety and security is a big one, and neighborhood environmental factors is a second big one, where there are green spaces, where there is, garbage isn't collecting on streets. So these two are examples of neighborhood influences that also promote mental health. So home, school, and neighborhood. But if I was 18 and or 16 and if I asked my son, what really matters to you? It probably will be the condition of the world. For young people today, actually, the single most important reason why they feel helpless, hopeless, angry, frustrated, isn't because the home situation is bad. It's actually because they feel that they've lost hope in the world around them. The rise of hate, climate change, And essentially, loss of trust with adults is a really profound issue that we as adults in our society have to pay attention to. How have we created this world in which young people are losing trust in their adults to leave behind a planet that's going to be safe and healthy to live in? And I think that is a genuine and real concern that young people have, and that is affecting their mental health as well.
Thank you so much, Doctor. I think that's actually a really important note to leave on, and I think it gives us a lot of food for thought as adults. I want to thank you again so much. I think Jimmy and I could continue and ask you so many questions, and we hope to in the future stay in contact. Thank you so much for everything you've done to help generate all this evidence for us to be able to draw on the science and really advocate for transformations in terms of mental health access and participative mental health care provision in the world, in our region and in the world. Thank you so much, and we wish you the best. We're really grateful.
Thank you, Selena. Thank you, Jimmy, and all the very best to all of you who are participants in this conference. I hope that maybe very soon we will all be able to meet in person. And I welcome you to Boston or Goa, my two homes. If any of you should visit, to get in touch with me. Thank you all very much. Bye-bye.
Thank you so much. Have a great evening. Thank you.